Good morning, everyone, and welcome to the Clinical Management Webinar Series by WHO Regional Office in the Western Pacific and also the representative offices to the Philippines. My name is Dr. Albert Domingo from the Philippines Country Office. We are fortunate to be joined today, Thursday, August 6th, the fourth of our third webinar series. Let me repeat that, the fourth session of our third webinar series. We are joined by colleagues from Singapore, Professor Tan Kok Hian and Ms. Pang Muklan, whom I will be introducing in a bit, to speak on the topic of patient safety and healthcare worker infection and prevention. So those are two very pressing, very urgent topics, not just in the Philippines where I am based, but also all over the region. And as we can see, we will be hearing from the Singaporean perspective, but there will be some general principles that we can all learn from, and I'm sure you will be wanting to ask your questions. So how do we do that? For those of us who are in Zoom, there are now 238 participants and counting. We expect that to go up in a few minutes. You can always use the Q&A button, which is located at the bottom of your screen. When you click that button, there's going to be an interface where you can type your question, send it. If you see other questions that are interesting, I reckon that you can always upvote. But don't worry, we will be reading not just that. For those who are on YouTube, on the other side, we will also be looking at the live chat function and reading your questions in the second half of today's presentation. There will be two speakers, and so that we can have as much time as we can for that discussion. Allow me to start introducing both of them. So for the topic today, which is on patient safety and healthcare worker infection and prevention, the first speaker will be Professor Tan Kok Hian, who is the Group Director and Senior Associate Dean of SingHealth Duke and US Institute for Patient Safety and Quality. He was previously KKH Campus Director of Patient Safety and Quality. He is the inaugural chair of the National Quality Council since 2017, which serves as a national advisory panel to the Singapore Ministry of Health on health quality priorities and strategies. Professor Tan initiated the SingHealth Patient Advocacy Network, or SPAN, in 2017 and serves as its advisor. He led in the cluster-wide implementation of TeamSpeak, an in-house cluster psychological safety program for staff and faculty to speak up for patient safety since 2017. Professor Tan is a member of the expert group on patient safety in the World Health Organization and serves as a WHO consultant in patient safety and quality. He received the WHO United Arab Emirates Health Foundation Prize 2009 as the KKH Integrated Perinatal Care Project Team Leader and the inaugural National Outstanding Clinical Quality Activist Award in 2010. Professor Tan was conferred the Benjamin Henry Shears Professorship by Duke and US for his outstanding contributions in the field of obstetrics and gynecology in 2019. He led in national evidence-based guidelines development of gestational diabetes, perinatal nutrition, and physical activity and exercise in pregnancy. That's just the first speaker. The second speaker is Ms. Pang Ngoc Lan, who is a registered nurse with more than 20 years of PICU. I'm assuming this is pediatric ICU experience. She was awarded President Nurse in 2003 for her professional contributions. Ms. Pang is currently the Director of Quality, Safety, and Risk Management and Chief Risk Officer of KK Women's and Children's Hospital. At cluster level, Ms. Pang serves as the Deputy Group Director of Institute for Patient Safety and Quality, SingHealth Duke and US, where she is co-convener and senior program faculty of AM-EPIC programs. She also serves as the faculty member of Singapore Healthcare Improvement Network, or SHINE, a collaborative program with the Institute for Healthcare Improvement. Please note that any discussions and opinions are those of the speakers and do not necessarily reflect the official guidance of the World Health Organization. Having said that, I would like to turn over the floor to Professor Tan Kok Hian. Professor, you have the floor. Please share your screen.
Thank you, Albert, for your kind introduction, and I'd like to welcome everyone for attending this webinar. Both myself and Ms. Pang will speak on patient safety and healthcare workers' infection and prevention in the context of COVID-19. Our scope covers, I will talk about the global and the local, means Singapore COVID-19 situation, patient safety and healthcare worker safety. And Ms. Fang will take the rest of the scope listed here. First, I'd like just to look at some of the countries in terms of their cases and death. These are some of the selected countries. As you know, the world now has over 18 million cases, so over 600 deaths, with a fatality rate of 3.82. USA is leading in terms of the cases, over 4 million cases, 157,000 deaths, and fatality of 3.31. So if you were to look at Singapore, we have 50,000 cases, 27 deaths only, and with a fatality rate of 0.05. If you look at Philippines, over 98,000, 2,000 over deaths, and fatality of 2.081. So this is the situation on the 2nd of August, just recently. I'd like to say that Singapore very low rate is due to a couple of factors. One is the healthcare situation in Singapore is quite, I would say, is quite good in terms of our resource planning, in terms of resources that we have, in terms of preparations, we are doing quite well. But of course, there are other factors that affect in terms of the case ascertainments and also the death ascertainments that affects the fatality rate. For example, if you are doing a lot of tests, then naturally your fatality rate will actually drop because you will surface out more cases. If your population has mainly young workers, migrant workers, or our workers locally, then you will have actually low fatality rate because, as you know, COVID, in terms of affecting the younger workers, are actually much better in terms of the reduction of the death cases. But if you have a very vulnerable group like in the nursing homes where they're elderly with a lot of comorbidities, then you will have a higher death rate itself. It also relates to the death ascertainment, the death cases ascertainment. So if you count all deaths that's related to COVID, then you would have a higher fatality rate. But however, if you attribute death only directly attributed to the COVID disease, then you might have a lower fatality rate. So this is the situation in terms of the global. I just like to take you through very quickly. So in January, there's the reported Wuhan cases. In February, WHO named it as COVID-19. In March, WHO declares it as an outbreak, a pandemic. In April, we reached 1 million over cases. And in May, other countries are affected. Initially, China, South Korea, and Italy, and various parts of Europe were affected. But now we're gone to the other parts like South America and North America. And now in June and July, going there is you have Africa, as well as South America. And there's also a resurgence of the cases, especially in South America and South Asia. So I just like to write a report in our Straits Times shows that in Philippines there is now a lockdown, and I think it was reported that a couple of days ago the health sectors felt that they cannot hold the line much longer. I think this is because of the number of cases and the fact that the healthcare resourcing in terms of facilities may not be able to cope unless there is a lockdown where you can actually reduce the number of cases and also reduce the transmission. Okay, here in Singapore, this is our timeline for Singapore. In 4th of January, we have the first suspect case. First confirmed case was 23rd of January. Then we raised our alert quite early on in February. We have our first death in March, and we have a national travel ban. And we commenced our circuit breaker. Our circuit breaker is actually our lockdown. That was commenced on 7th of April. And as now as you approach May and June and July, we are actually gradually opening up after our circuit breaker. As you know, there was actually an outbreak somewhere around May of a spread among our migrant workers population, which I'll show you in the other slides. So here, this is the infection relating to Singapore. As of the 1st of August 2020, we have over 52,000 cases, and of which over 44,000 have completed their isolation. We have only 25 cases of death, and currently there's no cases in the ICU. So if you see here, the vast majority of Singapore cases are relating to the dorm residents, where out of the over 52,000, over 49,000 are related to those staying in the dorm, the migrant workers staying in the dormitories. The community cases, about 2,000 cases, and imported cases, about 700 cases. So this is the epi curve relating to the Singapore situation. If you look at the lower chart, basically for imported cases, 700 cases, we have the first wave, that's from Wuhan in February. And then we have the second wave around March or April, that is from Europe and other parts of the world. And now we have very little imported cases, and that's because we are opening up, and that is from some of the workers that come along back to Singapore. As you see the community cases, there is a spread which is peak at around April, and we are actually controlling our community spread. Total is about 2,000 over cases. But as I mentioned before, over 94% of our cases in Singapore are related to the dorm resident. There is a large outbreak among the dorm residents who are staying at close quarters to each other. But however, we are able to manage and contain that by setting such that we are able to project our medical resources into the dormitory as well. So we actually do not let the infected or those who are suspected to come to the hospital, to General Hospital, but we are able to set up resources to be able to triage, to be able to test, to be able to trace, and to be able to isolate them at the site itself. Okay, this is our circuit breaker, which is our lockdown itself from 13th of April, which was extended to the 1st of June 2020. And during this circuit breaker, the workplace are closed and only essential services were allowed. Eateries only allowed takeaway or delivery, and the schools are shifted to full home-based learning. As you know, since the 2nd of June, we're actually opening up. So we have actually in gradual phase where we allow bigger and bigger gatherings, from 5 to 10 to 50 to 200. But when we reach phase 3, which we have not reached that, I would think that we will still be practicing a lot of precautions like safe distancing. Okay, I would also like to stress certain aspects of patient safety because that relates to healthcare worker safety. So as you know, in this pandemic, there are certain, this is an unknown disease with multiple phases and with certain unknown characteristics that was in the beginning because there was a lack of understanding and poor evidence in the knowledge of effective treatment and prevention. Only now we begin to know what drugs are good. For example, dexamethasone given during the later part of the disease is actually useful. Remdesivir is also useful. And there's a controversy relating to hydroxychloroquine. But if anything, it has to be given early for it to be effective before the cytokine storms. And then there's also the issue of relating is the overwhelming surges for the healthcare resources. Especially the first wave is particularly vicious because most of the healthcare facilities are not prepared. They do not have the resources, the supply chain ready. They have not have taken practice in the ability to be able to test as well as to be able to trace and also quarantine or isolate the infected cases. There's also the high transmissibility in the community, which we found later, that this awareness that there is significant asymptomatic and pre-symptomatic transmission. So, so because of this, because of community transmission, and I think that's why the mask, there was later understanding that everyone should wear masks to reduce this particular fact itself because of the pre-symptomatic transmission in the community. And a very important concept that come out is the concept of safe distancing. And I think it is a key element of infection control here. And it's also a challenge to implement in all spheres of activities, because it's not only within the healthcare setting, it's about the community practicing safe distancing itself. And that requires a lot of education. It's a whole new game changer altogether. And also very important is that we have to consider something beyond the infection risk. Because if we were to just lock down, there are also other risks that we have to consider that might crop up. Livelihood risk, because if you were to lock down and the whole economy goes into a contraction, people lose their job, that will affect family health. That may even increase, emotional abuse because of the family health issues arising from the lack of jobs or lack of income. There's also the mental health risk that when people are locked up in a lockdown environment where they're unable to do their usual activities. And there's also the issue of the usual management of chronic diseases, because that will not be so well done in a situation where there is a lockdown. And this new scenario is not going away. It's going to stay here as the new norm. As you can see, there's a lot of resurgence everywhere of this case. So we have to be taking into account all these aspects. I just want to mention, this is a tweet from UNICEF. We know that children and young people are not the vulnerable populations in COVID. The death cases usually comes from the vulnerable group, which is the elderly with a lot of comorbidities. But however, COVID can affect in a different way, because it can actually disrupt food supplies, create livelihood issues, affect family health. And that's why in this tweet, there was a warning that 10,000 more children could die from malnutrition because the food supply chain is being disrupted. So we need to be able to bear in mind all these aspects itself. And that relates to the patient safety model. The patient safety model is important because patient safety is a discipline that applies safety science methods towards the goal of achieving a trustworthy system of healthcare delivery. It minimizes the incidence and impact of errors, adverse events, and maximize recoveries from such events. So it must be applicable both in normal times and in new and disruptive scenarios like what we are seeing now in the COVID-19 infection. Similarly, there's been a lot of recommendations on how to have a good patient safety systems. So these are the 8 recommendations that has been advocated: sustaining a culture, coordinated care, creating metrics, increased funding for that, address safety across the whole care continuum, supporting the healthcare workforce. That's very important. Partners with families and ensure technology is being optimized to do that. But however, it has to be effective, not just in the normal times, but in also disruptive scenarios caused by pandemics like COVID-19. Right, so what can happen if we don't have a good patient safety model, or we are unable to bring our patient safety situation strategy up to par? Then we will have all this that can happen: poor or no access to an overwhelmed hospital, inability to triage overcrowding, long waiting time, inability to manage the usual acute and chronic cases. There would be multiple transmission of COVID-19 infection, both within the healthcare facilities as well as also outside itself. There's severe medication, blood, and equipment shortages resulting in poor care because of the disruption of the supply chain, and we are unable to be able to cope with that lack of shortages of the equipment. There will be an increase in sentinel events because there is extra work, extra procedures, confusion, and stress from the changes affecting our healthcare workers. There may be shortages of working staff from staff stress and breakdowns. People will take MCs, they may not be around because they are infected. There will be poor and lack of training students and other staff, resulting in poorly competent staff, breakdown of care coordination, and also new issues that might come up. For example, if we are talking about telemedicine has its own issue, confidentiality, and whether it's actually effective in diagnosis and the delivery of care. There's also another issue as well. So these are some of the patient safety adverse events that actually occurs. I think this is happening in Singapore, patient identification errors, delay, as well as various aspects in terms of the lab error. But fortunately, there is no, we calculate in Singapore, there's no excess sentinel events that occurred as related to this COVID-19 pandemic. So another very important concept of the quality care is that besides the 6 elements which you are familiar of, effective, safe, people-centered, timely, equitable, and efficient, there's a need for integration across the whole continuum of care. And that point is actually being stressed when we actually meet earlier in the day, where we meet together for some of our patient safety experts at our global patient action safety plans in terms of the safety and quality across the continuum of care. There should be good integration for patient safety. So just to summarize, one of the tenets of patient safety in this particular crisis, I think what we need to see for care to be good, to be effective, as well as for good patient safety and good healthcare worker safety, we need to have multidisciplinary, multi-professionals across the whole continuum of care. We also need to have a system that is dynamic, that is proactive, flexible, and adaptable in this fast evolving environment. We are prepared to accept new evidence and to incorporate that. We be prepared to set up outposts, facilities outside so that we won't jam the hospital environment. We need to be holistic in our thinking, because the infection control now is not just a healthcare facility issue, it's a community, a workplace, and an environmental issue itself. And as mentioned, it's important to take into account population health, mental health, as well as supply chains when we are talking about how to tackle the COVID-19 crisis. And that's why the WHO and a lot of countries are looking at it from the whole of government and whole of society approaches. So then what can we do to have good patient safety activities that are effective for this particular crisis? We need to be prepared. We need to be proactive to deal with the surge and the unknowns. And as I mentioned, where there is the first wave or this epidemic curve, it is important to flatten it, right? Flatten, we try to be able to prevent the facilities and resource from being overburdened by the surges. I mean, lockdown is one of them. Increasing the concept of safe distancing and the buying for safety is also important. This is to buy time to avoid being suddenly overwhelmed in a short space of time, as well as to gain time for new knowledge and new treatment to come on board. So we need to be flexible and adaptable to the evolving changes as well, to be able to project our healthcare resources through the ground itself, to areas where it's affected. Projection capabilities like be able to triage, be able to test, able to trace and isolate cases. Scaling up, scaling down, able to recognize and mitigate and balance risk among the various activities. For example, when there is a shortages, then you have to balance the risk of whether it should be single use or multiple use. A lot of times we use single use to reduce infection, but when there's a shortages, then we may have to convert to multiple use, but with the mitigation of risk and in terms of infection. Of course, we need to accelerate trials and innovation and also adopt evidence-based medicine. So I just like, because this topic is about healthcare worker safety, healthcare worker safety is actually equivalent to patient safety. Because if the healthcare workers are infected, it's actually a patient safety issue as well. And if healthcare workers are well rested, well resourced, and well trained, well planned, then you can actually enhance patient safety. So this is a very important aspect itself. In Singapore, we have done a study and found out that actually there are very few healthcare workers that are actually affected by COVID-19. In fact, there's a study that shows 66 confirmed cases, but the evidence shows that they're actually not infected through their work because they take the precautions very seriously. They're actually affected by the community when they go back home and then they get infected along the community. And that's why community transmission is also very important to understand. So everyone, including healthcare workers, have to be aware of this particular fact itself. So as I said, preparation, planning ratios, protective equipment, all play a part in preventing the healthcare workers from being infected. Of course, there's also a discrimination because healthcare workers are thought to be at higher risk of that. So there's discrimination. But however, I find that in COVID-19 compared to SARS, in fact, healthcare workers are now less discriminated. A lot of people in Singapore, at least in Singapore, we regard the healthcare workers very highly. There was a lot of tributes given because they are the warriors in this COVID-19 pandemic, fighting this war to help to reduce transmission and to get the country going itself. So, and also, for example, in KK Hospital, there is a lot of activities to promote healthcare workers' safety. So like, for example, in rapid succession, staff communication, practicing donning of the PAPR, as well as the PPE, ensuring there's adequate supply. We elevate it, in Singapore to alert level higher, and we actually deal with the enhanced measures that as a result of that. We do temperature monitoring for all our staff. We have staff clinic to ensure that staff who think that they are sick, they are able to seek care and be able to test and be isolated if they are positive. We have a carer support, and we encourage our staff to stay vigilant. So there again, we encourage to work from home if they are not doing any clinical work. Ring fencing of patients area, we encourage safe distancing. We have also encouraged safe distancing measures as well as audits, both from the point within the healthcare facilities, and also there's a national, so-called management of the safe distancing, because we have safe management officers that is both in the healthcare institution as well as in the country itself. We also encourage to leverage on technologies for video consult and of course continued vigilance, which brings me to this very important concept of safe distancing. Infection control has now brought onto a new level, a new game changer, where it's brought onto a higher level, because we realize that if we want to reduce the spread, we need to work on it in not just the hospitals, but also in the workplace and community. And safe distancing means reducing the spread of this virus by increasing the distance from possible exposure. So there could be social distancing, the 2 arms rule, length rule, the 1 meter physical distancing, split work teams, stagger hours, avoid handshaking and hugging. There's barrier distancing, the encouragement of use of masks, PPE, hygiene distancing, encourage hand hygiene, personal and face hygiene. Activity distancing, avoiding gatherings, large group gatherings, group activities, and including singing and vigorous talking, which might actually promote transmission. We also encourage the use of tele activities and work from home, and of course the environment to play a part in terms of the ensuring that it's safe. So I just want to show this as an example that we should have rapid response to the changing situation based upon the best science available. When it was first started, the public is not encouraged, if they are not symptomatic, not to wear masks, because mask was in the shortage at that time. And there was no evidence that actually mask at that time is useful. But there was increasing evidence that there was asymptomatic and pre-symptomatic spread, as well as community transmission. Then this has actually changed. In fact, in Singapore, since as early as in April, we have actually encouraged compulsory masking. And mask is actually been given out to all residents of Singapore just before this rule come on board. Okay, now thank you very much. I will now hand it over to Ms. Pang, who will take on from here now. Thank you very much.
Thank you, Professor Tan. And come in, please, Ms. Pang. Ms. Pang, please check your microphone. You might be muted. There.
Yeah. So can you hear me?
Yes, loud and clear.
Yeah, okay. So I will touch on the national preparedness and also the effective strategies, because that is very, very important, as that, how we map our plans. And we are very fortunate that we have the country leaders has very involved in giving directions in the kind of measurements that we need to have. So the good preparedness, if also the institutional memory of SARS and H1N1 has been very, very helpful for us to move on to this pandemic. So why Singapore respond actually work? I believe that because we work very closely in collaboration with everyone, so which is very, very important, and also translating lessons from the SARS and H1N1 to COVID that really help us to prepare a lot of our draw plans in place, so that when pandemic sets in, we are able to use it very readily. So it's being emphasized even by our key leaders that 5 things we need to learn from this lesson is really about following context where you have the infected, you want to separate them, and keeping people who are positive in the hospital. But in our hospital, which means that in Singapore it may not be acute hospital, but really the community sites. And also strong and regular communication on what people can do to minimize risk is very, very key, because we need information and the people need to have a guide as well. And not, of course, getting people to get locked down and fearing that, they will lose their livelihood. So organized leadership is very key. And if you look at, our government sectors, we adopt rapidly a new information and support and rapid disseminations of new information and practices through the website. And they developed the website with also the COVID-19 info board that you can ask questions and the board will be able to answer. And in there are many guidelines that telling our people that what to do and how to keep themselves safe. And more importantly, also that we need to establish a strong command and control, communication with the ID, epidemiology as a core, and also we need to pool the resources and also build such capability to risk mitigate, and also that we need to ensure that we have backup facilities. And for us, we have the MOH multi-ministerial task force that actually, cascade down information to the cluster disease outbreak task force, then to the hospital, and our hospital has a command post which operate every day. And that information has to be bi-directional, and that's where the information can, pass through and easily make helping us to make that decision to know what to do. And we are very fortunate with the SARS experience. We have actually put in place a national public health institution where solely this institution is dealing with very high level the outbreak cases, where we isolate them into different rooms, and these rooms are very sophisticated as well. So we must not, overwhelm our acute hospital facilities, because some of the patients coming in may not require, the kind of care that the hospital's patients needs. So therefore, healthcare support has to go beyond hospital if you look at the pandemic, because we have to house the milder cases in the community care facility that quickly put out by the government agencies. And also those patients who are recovering, we need to put them separately as well. And also for the patients that's waiting for the swab, results, they have a special, also facilities to house them until they get the results, and they're able to, go to whichever places that is designated. So containing and risk mitigate is important, because we want to avoid crowding the hospital. So we have to send medical teams to the sites rather than, having the patients coming to the hospital, because the kind of resources is very draining, and we do not want, our vulnerable patients to get infected and the hospital is not able to function to service the normal cases as those acute cases. So it's important that this strategy has to put in place. And we must embrace on technology in the COVID fight, because we need to reduce the amount of time that the frontline workers spend with the COVID patients. And we have actually put in the telemonitoring solutions for the COVID patients that, you know, we monitor the patients using these, you know, the telemonitoring. So for us in in Singapore, we don't have many ICU cases. Total so far, with 6 months down the road, we have about 128 cases. And now, I think for a month, we has been zero numbers. And I think what is the reason for us not having that many of the ICU patients? Partly, I think because we are prepared in a way that, you know, we timely, you know, stratify them and, you know, put them in special, you know, community facilities or in an acute hospital or even NCID to treat them. So these patients who are really ill, they can actually get enough of care from the healthcare workers. And the other, portion of it is that, you know, our Singapore has actually invested in a lot of the healthcare, and also not just on the equipment and facilities, but also the human capital as well. So our staff and our people, the doctors, are very well prepared in managing this group of patients. So institution infection control prevention is very key. And we are looking at how to minimize risk. And there are many options to consider to minimize the transmission of COVID, because we can actually do the telemedicine to avoid physical visit to the hospital. And we require also, you know, the change of protocol in managing triaging at the front line, make sure that, you know, we screen the sick people and do not allow them to be in. At the same time, we also have the telemedicine that, you know, home delivering of medications instead of having them, you know, coming to the hospital to collect the medications. So there are many things that put in place. Virtual consultations will help to reduce risk of exposure. And of course, there are also safety issues within, you know, telemedicine. So therefore, we have to put in with risk mitigation strategy to manage, you know, the confidentiality of patients' information as well. So medication delivery, as we say that, you know, reduce the dwell time in the pharmacy and the risk of transmission, even for the outpatients. Patients can actually sign up for the service, and they can actually get the medications within 3 working days. And the patient also can actually opt to collect the medication at certain lockers, which is designated in, you know, the convenience store. So minimizing the risk of admissions, there are also many options that we leverage on, where, you know, we look at the patient whether they require to come in or not, especially those elective cases. Those can wait. We may want to actually prolong them, as that, you know, they would you know, reserve the beds for the more sicker until the situation is better, that we will bring them in. So we also try to look at whether the patient can stay on the same day and be discharged quickly. And some of the pre-rehab patients, we may teach them early so that they can rehab. After the operations, they may be able to go back to their home and continue their rehab therapy. So besides that is triaging of the admissions, and also track patients' movement, and also even in the conducting of the patient safety round, clinical rounds, we limit the numbers, and we try not to get you know, our team go to the patient's cubicle, but rather make the discussion outside, and you know, try to have a very little dwell time within the cubicle itself. So apart from the PPE, hand washings, and also designated room and facilities, and also we leverage on robot as well. So for infection prevention, we need to adapt and harness disruptive change, because things move very fast and evolve very fast, and that, you know, sometimes the information come on board can be, you know, quite disruptive, because we do not know whether, you know, which information is actually more accurate. So it's important that, you know, we put in measures to make sure that, you know, we have enough communications timeline to be able to get the information cascade down and be understood. Yeah, and for the children's emergency, we have you know, designated different areas, so that, you know, that we will reduce the risk of contacting the COVID. So healthcare worker safety is important. Masking up, as earlier on Prof. Tan has mentioned about safe distancing, and that is the norm. And even for the mask preservations, we have a guideline to say that how to preserve your mask, because sometimes during meal they may take off the mask and contaminate the mask and put on onto their face, which is quite dangerous. So therefore, we even teach our staff how to preserve the mask for the day. And it's important for us to also have the daily update of PPE status and also stockpile, because we want to make sure that our staff are protected. So they must have enough of this PPE for the staff, and the top stockpile must make sure that they are sufficient. And of course, innovation for staff safety as well. We Impact SG Safe has actually designed this special booth for swabbing, and that actually give a less contact for our people. And refresh, we need to reinforce the 3PE, refresh and retrain people, because our code blue, the way we run may not be the normal code blue that our people just go and rescue our patients, but rather that they need to dawn on and know how to put up the PPE in, and where is they can put up the PPE before they actually attend to the patients. And safe distancing measure, earlier on, Prof. Tan had already mentioned about social distancing, barrier distancing, hygiene, activity distancing, and also the environment distancing. And we also sometimes look at the risk factor. If we are not able to do certain things, what then the factors we will consider? Time, the duration of exposure, the distance, and also the shield. So our staff safety, we look at temperature surveillance. Every day, the staff have to take temperature 2 times a day, and this is being recorded. And the system can actually surface those staff with fever, and the task force will actually do the follow-up. And we also designate staff clinic for the staff to go. And it's important that we have also check in for the movement of the staff, check in, check out as using the technology to help us. Also, we have these Trace Together apps where, if any contact, it's easy to know who are the people you have contact with. And safe workplace become a norm where distancing is key. So we have redesigned our workplace and even look at whether the staff can work from home, segregate the lunch hours, break many times instead of having the staff to congregate together. So workplace safety is important. So we do a weekly audit and make sure that, it's not really to police, but really to make sure that the staff is safe in their workplace. And we do education as well during our safety round to make sure that people understand why it's important for them to have the distance and masking up. And of course, the campus in the cluster, we also have auditors externally who come and do the audit, and that is also a criteria to say that whether we fully met the target. So out of the indicators or the observation they made, they must be 90% and above, then they have fully met the target. If not, they have to follow up and make sure that they meet up to the standards. And of course, the safe distancing, even you look at the lift, it's designated footstep, and there's not more than 6 people in the patient's lift. And we have dividers and we have segregation. Even we designate, the meal area, because we cannot congregate, so the staff have to have alternate site to have their meal. And more importantly is, we have to go on to ensure that, the staff are being taken care, because we can't get them not to have their meal. But after having their meal, next person is going to sit on what they're going to do with the table. They have to do wipes and, their hand rubs, on the table. So, but apart from that is really using the technology, using teleconferencing with Zooms. And we limit the people in the meeting room as well, even in the toilets, and also the use of the lockers. So staff well-being is important because healthcare workers are most important resources in the battle. So, but then we have to know that fight against virus, if it's getting too long, they get fatigued. So we do have many of these programs that put in place for the staff well-being. And every now and then, periodically, we have a thank you card. We have, special visits from people who give us food. and the staff are actually very well taken care of. And besides of the, the guides that we put in everywhere, what they must do, the checklist, we also look at psychological safety, physical safety, and also how to sustain the joy in work. So for that, we have iTry program that put in place. They can go online if they feel that it's stressful, and also there are also the care groups that they can contact to talk to. And we have also, many of the resources available online, and so they can seek help with. And these are some of the bulletins that they came up with, and it's very frequent. And more importantly, I think we are very fortunate in Singapore because we have a lot of people recognizing the effort of the healthcare workers. So we have a lot of visit from them, giving us food, treats, and all these are really very, very helpful for our staff. Yeah. And also we have sing together where they encourage the frontline workers to battle, with kind of support given by the people in Singapore. They clap for Singapore, clap for the frontline workers. And they also sing, during certain time where you can see that all the housing board, they open the window and then they start singing at certain timing. So it's very encouraging. Even our Prime Minister sent a Valentine notes to the nurses and the medical frontline people. And so in summary, we just want to re-emphasize that it's so important to look at what measurements of success in managing of COVID. It's really about the detections, break the transmission chain, adequate medical resources, and we want to minimize complication and death. Plus that, it's very important to protect our healthcare workers, protect the vulnerable group, and maintain the usual healthcare service for our people, provide adequate financial support for program scale up, and the livelihood of the people must be secured. So the take-home message here is really that, high preparedness is important. We have to build up the search capacity. We have to learn, adapt, and also innovate quickly. Holistic approach, we need to engage everyone, and also risk stratify and managing risk in the very optimal and dynamic situations. Things like ring fencing, equip, and ensure staff safety, identify and manage the people who are vulnerable, engage and empower our patients as well. And we have a new protocol. We need to make sure that it's practical, flexible, and there's interdependency. And that's where the new norms, we have to live with it now. So with that, I thank you very much for, taking your time to attend this webinar.
Thank you so much, Ms. Pang. That was and Professor Tan. As always, that was quite very loaded with lots of information. And we do have around 570 participants right now spread across Zoom and YouTube. So for those on Zoom, I see there are already 15 questions, but just in case you have not yet typed in your question, there's a Q&A button at the bottom of the screen. And for YouTube, there's the live chat. I'm also monitoring that forum as the moderator. So just a quick recap of what Professor Tan and Ms. Pang said. So it's about detecting and breaking the transmission chains. Sometimes we go to population health. We want integration to happen. Curiously, Singapore calls the lockdown a circuit breaker. Over here in the Philippines, the latest buzzword is time out, but it's been called many things also, ECQ, MECQ, GCQ, and the many kinds of community quarantine or CQ. And then one thing that Professor Tan said quite emphatically, healthcare worker safety is patient safety. All right, and that's where I start taking the questions, and I'm gonna do a little warm up here. So anyone who wishes to answer Professor Tan or Ms. Pang, just let me know and speak up. So very practical question. In Singapore, when do you clear a healthcare worker for return to work after being diagnosed with COVID-19? Do you still do a test-based strategy, or do you now do a time-based strategy? Professor Tan or Ms. Pang?
Okay, for us that we know is both, because beside the testing, we also make sure that the staff go on absent leave for at least 2 weeks. Yeah. So apart from testing negative, we want to make sure that they have enough time to also recuperate as well, and make sure that they won't get stressed when they come back to the working place. Yeah.
Yeah, I just like to add on that initially, when we do not know what exactly the COVID-19, we're beginning evidence. In fact, we actually generate evidence that perhaps a time base might be a more important rather than a test, because it could be positive throughout, and if you are tested positive, you never actually get back. And there is some evidence that shows that it's actually a time base. You can be positive and yet you don't transmit the diseases itself. And I like to emphasize, we must always go back to our data, look at it, and do evidence-based medicine. So whatever I'm saying may change depending on what data my own local. But I believe that they are changing to a time base rather than a test, because you cannot be testing them all the while, and it may not be able to give you and also give you the confusion of reinfection. Sometimes your negative is tested positive, but is it really a reinfection? And then again, we need more data all over the world to come to a conclusion. What is reinfection? How long is it infectious? That is the more important data that we need to establish itself. Yeah.
Thank you, Professor Tan. That was spot on. There was actually another question that I've been able to dismiss already. So Dr. Charles was asking if there has been reinfections, and you quite stated that already, that we are still looking at the evidence. Is this like a positive already, but a non-infectious, not a reinfection? So that's the answer to that question. Now, Lester Sigabu is asking, did Singapore use an antibody-based test as initial diagnostic test for COVID? Why or why not?
Well, again, it's actually the evolution of the test itself. The best test, because it's the antigen test, so you do it, but it's not on the spot. It takes maybe one day, you do it in the morning, it comes back in the evening time. But now there are more and more tests coming out. And I'm sure that people are using a mixture of tests, because if you have an on-the-spot test that can tell you immediately the result within half an hour, you will actually use it. But then again, you must be sure that it's been effective, it is accurate as well. So there's so much variety of tests, so it's impossible for me to actually answer exactly what is. Of course, the antibody test has its advantages and disadvantages. I'm not an infectious disease expert itself. The antibody test means that you have been infected, but whether you are infectious or whether it's a prior infection, we don't really know itself. So I think we have to take that. My main message is that we need to, as the test evolve, we will actually do the best test that would be makes sense to us. Yeah.
Right. Thank you for that. So quite a few more questions. This one is a bit more practical. So as a medical intern, an anonymous attendee is asking, as a medical intern, we were told to go back to the hospital this September, despite the increasing number of cases. And we have doubts as to our safety being assured because these are trainees. So no hazard pay, no insurance. Is it safe for us to go back? Maybe the question, Professor Tan and Ms. Pang, is, in your experience, do Singaporean medical trainees, are they asked to go back to physical clinical classes, or is there a different mode of learning?
So for us, it's really a different mode of learning. Initially, we actually stopped the trainees from coming in because we are unsure of the situations. We don't want to put risk to the trainees. But subsequently, when we know about how we could make sure that the trainees are protected, we gradually look into even like the Zoom teleconferencing, to do the teaching, even the online teaching. But then sometimes we may not be able to avoid gathering, because sometimes there's a clinical round that the people need to go on to really experience. Then what we have to put in place is really about the protection for the staff. So they have to ensure safe distancing. At the same time, the group may be smaller instead of having a big group now, and so that distancing can be maintained. Plus that in which area they are going to, they have to also adhere to the strict PPE.
Yeah, I just to add that it's very important that even as you go back, you have to appreciate the need for safe distancing and to adopt all the safety precautions to do that. However, it's actually an assessment of the risk. You know, the risk for example, in Singapore, initially when we are at the full blown of the circuit breaker, we don't allow any students to come in. But as we gradually open up, we actually allow students to come in because they need to learn to be able to do things themselves. So it's actually an assessment of risk both by the university, by the government, and also it should be a discussion among all the learners. What would be the best way to be able to go forward itself?
Thanks for that. To another domain of questions, I'll start by reading one from Vincent Balangawan. And his question actually is long, but I'll just summarize. How is the implementation in Singapore when it comes to non-pharmaceutical interventions? Our colleagues here are curious, like, for example, if there is a citizen who is not wearing a mask, assuming that the regulations require a mask, so how would you affect? Is there a penalty? Is there like a consequence for not following a required non-pharmaceutical intervention?
Yes. We are very strict about it because it's not about the individual, is affected. We have to take care of everyone. So I'll believe that, if the person is not wearing mask, we have to find out why and what's the reason. It could be a medical reason, and that is something that we have to inquire. But if there's not a medical reason, then possibly that we have to make sure that they adhere to it strictly. Otherwise, they cannot come to the hospital.
Level 2. Attention, all medical
Right.
staff.
So it's more of the hospital refusing entry if measures are necessary.
Level 2.
All right. And I see another series of questions about the community. So Dr. Limuel Abrahenia said, thank you for the presentation. What measures can we make to protect, or can we do to protect healthcare workers in community settings? As it seems that most patient safety recommendations are hospital-centric. So what about those in the community?
Well, actually, when we project our care to the community, whether we set up a facility there itself, the patient safety would still be the same. It applies if you're a healthcare worker in a hospital facility, if you go to the community hospital, the community facilities, if you go to a post that has been set up, you still have to take the usual precautions in terms of safe distancing, in terms of PPE, in terms of masking, as required in the protocol. I see no difference in that.
Right. This next question, it might be in the Philippine context, but you might also have some advice. So over here in the Philippines, a lot of watchers or companions accompany patients. So in your experience, if there is a patient companion, how is this patient companion handled? Are they also screened or tested for COVID? Especially since they could be staying with, again, context specific, they could be staying with the patient in the hospital when needed.
The question, is it asking about the COVID positive patients that need caregiver?
Yes, yes.
Okay, so we have our kids in KK hospital where we allow parents, because it's very, very difficult for the child to be separated because they have the separate anxiety. So the parents will be allowed to stay, and they have to also take the necessary precaution like wearing masks at the same time, and they will be tested as well. Yeah.
Right. So the time is 11:59. Is it okay, Professor Tan and Ms. Pang, sorry, if we extend just a bit? Okay, thank you so much. So Dr. Cristina Pascua is asking, is it possible that anesthesiologists who come in and out of COVID wards and then do operating room cases after, can they cause, in your experience, have they been causing cross-contamination, or is there a safety protocol for that specific kind of a health worker, anesthesiologists?
Yeah, I think I didn't actually show the slides, earlier on because I thought the time factor. In fact, we have new protocol even for the anesthetists who is going to intubate patients. In fact, the new protocol require the surgeon who are operating to go out the room. Yeah. So during the intubation procedure, there's a timeout where, you know, the surgeon have to leave the room, the scrub nurse have to leave the room. After the intubation, then they will actually, you know, have allowed the entry, and this is in the timeout itself.
I just to add that we actually try to restrict too much movement here and there. In fact, we ask some of the teams to actually work in teams. You know, you don't do that, especially in the midst of the outbreak during the circuit breaker itself. So they don't have too much movement. They don't come together a lot. But however, an anesthetist should be able to move as long as they take the certain precautions. For example, when intubation, they are in full PPE. And so if they want to go out to do something, they go to the, let's say, to the ICU. They are allowed to, because they have followed the protocol in terms of the transmission, in terms of reducing transmission. So that shouldn't be a problem. But having said that, I would rather not the anesthetist to be moving everywhere, because you know, the more you move, the more you come into contact with your own fellow residents or doctors, you're going to actually increase the risk of the transmission, even though you have done all the full precautions.
Thanks for that piece of advice. So we'll zoom out a bit from the hospital and go back to the community. I'll start off by reading something that Rebecca Lim typed into the chat box. She said that, I think it is not community hospitals when you go home around the communities as they go along. So maybe I'll just use this as an opportunity to segue to remind that tomorrow, the session tomorrow, Friday, August 7th, is about community care. And we're gonna have, I think, Dr. Donald Lee, who will be joining us tomorrow to speak about that. So we can ask him also that. But for this discussion, I'd like to bring up something. So an anonymous attendee is asking, does spraying using disinfectants have a role with the prevention of spread of COVID-19? So we see a lot here in the Philippines. There's a lot of spraying going on, spraying on the street, spraying in the hallway, spraying in the car. Does this have any bearing on the prevention or breaking of a transmission? Over.
I do not think that there's evidence to say that it actually helps. Psychologically, it might help though. So, you know, sometimes you need a bit of obviously I spray so that I'm quite in a safe environment, but psychologically it may help. But as you know, it has to be applied effectively. You know, when you put on the alcohol swab, it's to your hands, so the hands don't transmit itself. So there's a specific spraying may be temporary. As far as I know, I haven't come across a paper that it actually will really help. And there's a lot of people who cast doubts about it. It's still evidence to be coming up. And so I'm not denying that it may actually be of help, but so far I haven't been seeing any evidence that relates to it. Yeah.
Yeah, plus on, I think we need to look at, you know, be cautious about it, because certain people, they are very sensitive skin, and sometimes you may get them to, you know, develop, to have spread out into rashes. And because we had that experience in one of the dorms where, you know, the dormitories, they brought in this spray, and actually the doctors are seeing cases of allergy rather than, you know, COVID.
Oh my! That's a very good. I mean, it's not good, but it's good for us to hear that observations like that are happening. So maybe we can be somewhat mindful when we do that, if at all. All right. You mentioned Professor Tan and Ms. Pang something about the mental health of healthcare workers. So one question here from MU Pasayan is that, how do you address the mental health of healthcare workers in Singapore? What programs do you have?
We do have care support, you know, within all the institutions, where the staff can actually link up with the care support group, so it's available for the staff. Besides that, I think the HOD themselves will be able to identify whether the staff at risk. At the same time, you know, we do have apps that, you know, looking at healthcare workers' wellness, and that is in the form of survey. In fact, this is being rolled out by the government, you know, .sg, I think. So they want to find out how's the well-being of the staff. So there are many programs that put in place to make sure that, you know, the well-being are taken care of. Of course, the usual rounding, the leadership rounding is also very key, because instead of lessen the leadership rounding, in fact, during the COVID, we increase our rounding because we want to make sure that the staff are well protected and well supported. And if they have any issues, they can actually raise it up during that platform, and we can actually support them quickly.
Yeah, I also like to add that actually, healthcare workers are, they are not all the same. Some of them are really very stressed by it, and we actually have carer support for that because they are so stressed by it. The majority, actually, what they need is actually the way to be able to make sure that they are safe. So we teach them proper PPE and everything, and they're quite happy about it. Then there's another group which because of COVID, they find purpose and meaning in their mission. In fact, these are the people that lead, to set up things here and there. So in fact, of actually, becoming depressed or what, they actually become very motivated. So maybe sometimes you need to identify these few people who, because of this, they actually step up to the occasion and actually help a lot in trying for you to try up to go get your mission of trying to reduce the transmission and to make everything better.
Thanks for that tip, Professor Dan. That's a very nuanced approach. So by no means is Professor Tan making a comparison like a contest. Like there are those who like to do this and who want to save lives, and then there are those who are tired. We just need to identify how we react to the stress and perhaps intervene. So if someone is motivated, that's a very good tip. So if someone is motivated, then let him join the leadership initiatives. If someone is stressed out and seems to be overwhelmed, then we need to deploy measures to care for these. All right, now I'm going to shift. It's 12:06, maybe one last series of questions. There's been mention earlier in the presentation, Professor Tan, about dormitories. And right now, here in the Philippines, there's a lot of talk about workplaces, especially in the industrial zones. And there's been a lot of debate like health versus economy. We can't impose a circuit breaker or a timeout or a lockdown, which is all the same. We can't impose a lockdown because it will shut down industry, and which brings us to the topic of dormitories. My question on behalf of the many who have been asking is, what has been the approach of Singapore, maybe your Ministry of Labor or whichever ministry it is, when it comes to guidance for the workplace, especially now that COVID-19 is happening?
Well, as I mentioned, most of the transmission actually, in fact, more than 90% occurs in the dormitory. So our migrant workers, they are actually about almost like over 300,000 of them, and they actually stays in dormitories. It can be small size or big size, but usually when they stay, they're actually quite close to each other. They like to socialize among each other, so the spread of it, is actually quite fast. So this was an area that, of course, one aspect is that they're actually young and healthy workers. They don't have comorbidity. So in fact, they are very low death rate or a low complication from this itself. So we need to, of course, balance the risk. This is not a nursing home where, for example, where there's infection, then you could have a lot of excess death that occurs at a particular period of time. But yet, we still think that the Singapore, I think, perception, at least what I understand from the government, is that the health of the workers are as important to the health of our own citizens, because we live all together, and we want to ensure that our workers in Singapore are really, if they are infected, they are taken care, they are isolated, they are given the best of care. And we are able to mount it. We are able to be able to send, pull up outposts to be able to test them, to do the contact tracing of who they have been to. We're able to isolate them, and then to separate the healthy workers and from those who are infected. And then we house them separately. So we create dormitories, from shelters, from unused area, from various factories itself, to be able to house them separately. So in the more distant area, rather than to be crammed inside a house where they socialize. So in a way, we felt that it's important, and we're able actually to control this. And so there's, at this point in time, more than 75% of our workers are actually cleared, and in fact, they actually cleared to be able to work now. So in fact, very effective. It's also, if you're able to handle it well, you're able to clear them up, clear them so that they can work. And all of them like to work because they want to have livelihood as well. But of course, when they are not working, Singapore government together with the company do support them in still giving them the pay to be able to sustain that. But we want them to be as healthy as possible, and also to go back to work, which is what they want to do itself.
That's a very nice last set of words. We want to take care of our workers because we want them to stay healthy and to come back to work, of course. And they are part of the general community. I see the time is 12:10. I think that it's always like this. The questions come in, especially when everyone gets stimulated with the answers, because your presentations, Professor Tan and Ms. Pang, have been very, very information-packed and dense. In fact, I'm going to ask, and I'm sure everyone wants to find out, can you share your slides with us?
Yes, of course, we would love to share the slides with all of you all, because we want to help. I mean, all of us should share our information so that as a world, we can progress and actually, counter this pandemic, COVID-19. Yeah.
Thank you so much. So everyone, you heard it from Professor Tan and Ms. Pang. We will be sending out the slides later. This broadcast, which is on YouTube, stays already. So actually, you can start texting, forwarding the link, and it can be seen already even after we're done. So while there are still 22 pending, 23 and counting questions, a lot coming in, the time is already 12:11, and we will have to call it already at the end of the webinar. I'd like to ask Dr. Gary Kuniyoshi and Dr. Sophie Dennis for any parting words.
Thank you very much. Just a huge thanks to Prof. Tan and Ms. Pang and Dr. Domingo for moderating as well. Just really valuable to get Singapore's insight into all of this. And it sounds like you've done an incredible job, and your effort is still ongoing, and it will be an ongoing thing. But I think it's really interesting for other countries around the region to be able to see the support that you're providing. So thank you.
Yeah, thank you.
Thank you.
Yeah, thank you, Professor. And then Ms. Pang, we really appreciate you sharing Singapore's example with the rest of the West Pacific region. Thank you very much.
Thank you.
Thank you.
So thank you so much, Professor Tan, Ms. Pang, and all the 411 in Zoom, but 133 on YouTube. So I think we may have broken our records again. It keeps on getting higher. But that's a good sign. People like to find out. And also as a reminder, not only for Professor Tan and Ms. Pang, but to all speakers, most of our participants are, if not all, are frontliners. So they may not join us live, but they do email and ask, send us the slides, send us the footage. We're gonna watch when we're off. So that's my way of saying to everyone out there, whether in the Philippines and Singapore, also in other countries in the Western Pacific, we'd like to say, please stay safe, be well, and we hope you can join us again in tomorrow's webinar, August 7, on the community approach to the COVID response with Dr. Donald Lee, if I'm not mistaken, the president of the WONCA, the World Federation of Family Medicine Practitioners. So until then, we'll see you there. Bye-bye.
Thank you.